who's an associate professor in the Department of Psychiatry and Neurobehavioral Sciences here at UVA. She does, as many people do in the health center, she has many roles. She does a lot of research in addictions. She teaches in the medical school and in the psychiatric residency program. She is a clinical psychologist and therapist, and so she has her own private practice. And she also practices and teaches a number of mindfulness-based interventions, as I mentioned before, including mindfulness-based relapse prevention and mindfulness-based cognitive therapy. She's a member of the directorate of the Contemplative Sciences Center. And I have to say I've been very fortunate over the past 3, 4, 5 years, number of years that we've been working together very closely on a number of issues. So, and Kim will be talking about mindfulness-based relapse prevention for addiction.
Thank you, John. That was excellent. I really appreciate that. And I appreciate being invited here today and your attention. I know it's right before lunch, so bear with me. I don't like getting that spot sometimes, but that's okay. No, it's fine. People don't look too hungry. They had snacks, so that's good. Yes, I am a clinical psychologist, so what I'm going to talk to you about today is some of the research, but also some of the clinical work that I do, primarily with addictions. And a lot of this will complement very nicely Dr. Shorling's his presentation, and hopefully augment that with a specific sort of focus on this population. I love this quote. I won't read it for you. You can read it yourself. It has a lot of meaning to me, especially with the population I work with. The people I see are typically people with pretty severe addictions and a lot of comorbidities, which means other sort of psychological disorders. And many of them come to our clinic and are almost in tears because this is one of the first places they've been treated, as they say, like a human being. And so I think it's very important to remember, even some of these people that the rest of society has given up on, we can help. I'm used to making the disclosure for my medical presentation, so I'm accustomed to putting that in there, but I have no financial gain from giving you this presentation. So the work that I'm going to be talking about is conducted primarily in locations around the country that I'm going to report from about other people, and then at the care clinic where we do our research on addictions. This is a picture of it. It's a unique combination. I feel very fortunate because I get to work with geneticists. My direct division chief is a geneticist, and we look at genotypes, phenotypes, and collaborate in a really interdisciplinary way. What I'm going to be talking about primarily, as you've been introduced, is the mindfulness-based approach for addictions. And as John said, this sort of grows off of the mindfulness-based stress reduction, but really targets a specific population. To talk really intelligently about this, I feel like it's necessary to give a little bit of background on the way we conceptualize addiction. And it is a little bit different than some of the work done on stress reduction, pain, depression, that sort of thing. So addiction, the way we would conceptualize it in a medical setting, as a psychologist especially, is that it is based on a lot of different components. So there's typically conceptualized a genetic component. This is why we have a geneticist involved. Learned behaviors, part of the reason I'm involved is I'm a learning specialist as well, as in learning theory, and physiological changes over time with the exposure to addictions. So it's a little bit different than some of the other issues that you involve yourself in other kinds of mindfulness-based interventions. So we have to consider all of that when we're looking at an approach to treat it. And the way the process is laid out here is a learning theory basis for addiction that talks about how you may have a genetic proclivity, but often a learned experience is the way people begin an addiction. So this is an example from a real person with also some comorbid social anxiety. Going to a party, he has some thoughts that it's going to be uncomfortable. He therefore then develops an emotion that comes around the time of the same thoughts. He stumbles upon the ability to drink, and this makes him feel a lot better. He's less anxious. This is the reward. This is learning right here. This is the brain soaking up the learning. I found something that works really well for my anxiety. And what happens over time then is this can get connected to a craving. And you see here, it can be through, you can have neutral cues. You get in your car. That's sort of neutral, but if it's connected with, in your mind, driving by the store to get some beer, it can produce a craving. Positive cues as well as negative cues can induce these cravings that either come directly as a craving to the person or generate some sort of affect. Negative affect, I'm lonely, so now I want to drink, or I'm happy, so let's go celebrate and have a drink. So you've got it from all angles here. These are conceptualized as producing cravings, and we can see cravings in the brain. We can measure them physiologically. We can measure them on paper and pencil. And these typically are what lead most quickly to the drug use. With the drug use, alcohol use, any other kind of drug use, you then have some sort of augmentation or decrease in the affect that sort of moved you towards that movement. So you feel better or you feel less pain. And then, of course, because we're human, I feel like I'm coming in and out with this, but I'm trying to stay steady, okay? Because we're human, we then attach thoughts to it as well, and we remember. And so this sort of augments it all. This just talks about the same sort of thing, but what happens is also that there are changes molecularly on a cellular level in the brain, just like John talked about, that we see both with the acquisition of drug dependence and chronic drug use, and then with abstinence. What I'm going to focus on is more of this abstinence component because we're talking about treatment for preventing relapse. So we've got some therapies that are pretty adequate, not great, but they can certainly help achieve remission of addiction and some abstinence. But the typical problem with treating addiction in today's world is that inevitably most people relapse. And so one of the reasons we're working on these developments for relapse prevention is to help decrease those numbers so that once we get people to a point where they're abstinent, we can maintain them there. And that means changing a lot of things. It means sustaining the behavioral changes, resisting the temptations that are provided with the craving, and it means, as John indicated, changing the brain again. It's changed once with the addiction process, and we need to sort of reverse those changes. What we know from the literature that is the primary cause of relapse, and this shows it here, up at the top, the negative emotional states are the primary reason that people report relapsing. So that gives us some clue what we might need to do to prevent relapse. What has traditionally been done with cognitive therapy, in my very complicated drawing here, is the cognitive therapies that we use now, or the medications, typically target the craving. So the medications target the craving more neurobiologically through use of medications like ondansetron and topiramate that have shown to provide some neurochemical changes that are associated with the patient reporting that they feel reduced craving. Now, this only works for some people, and what we're finding is that it's really seems to be based on genetics. I'm not going to go into all of that, but there seem to be genotypes who respond to anti-craving medications very well, almost 100% rates, and then genotypes who respond not at all. So it's not really going to be a consistent sort of method to treat these cravings. The other thing that we see, there's research coming out, this is only in rats right now, but it seems to differ depending on where you are in your stage of addiction process. So different anti-craving medications work better early on in the process while you're still becoming addicted, sort of early phases, maybe when you're binge drinking. And some medications seem to work better later on once you are dependent, because they are sort of physiologically different. But for with respect to therapy, basically the cognitive behavioral therapy approach has been to do behavioral strategies like avoid the cues, don't drive by the store that you typically get your beer, or do substitute behaviors. This is doing things like chewing gum, drinking coffee instead of smoking, that sort of thing. So, and there's cognitive components as well that talk about belief systems and changing some of your automatic thoughts. But by and large, these are only moderately effective, and we still have a long way to go with respect to treatments. So with respect to relapse prevention, what it appears from some of the literature I just showed you and the thinking in the field is that what we need to do is exactly what John described earlier, is think about ways to uncouple these linkages here. How can we uncouple the craving feeling from the drug use? And perhaps even how can we reduce the stress or the craving to begin with? And if we could figure out ways to do this, then not only might we reduce the likelihood of drug use, but prevent relapse to full-blown dependence again. So this was the idea that Alan Marlott had back in the early 80s, and he's a clinical psychologist who is unfortunately now deceased, but he was out in Washington and was a practitioner, a meditator himself, a practitioner of meditation, and he decided to try and use Vipassana meditation with a population of heavy alcohol and drug users to see if it might help uncouple some of this stuff. And so what he worked with was he had a sort of a captive audience to at least do this initial study. It wasn't a great study, but he had these incarcerated people who were readily available, and they came in and he recorded their use before coming to jail, and he had a mixture because it was a convenient sample. So he had a mixture of people smoking crack and using marijuana and alcohol dependent. But what he found is after 8 weeks of teaching them this meditation, and they actually did meditate, they meditated in jail. Once they were released, he went and recorded, different changes, and they did demonstrate different changes in their psychiatric problems, their intake of substances, and their optimism. So he found a lot of these sort of similar factors that Dr. Shorling was talking about were improved in these folks once they were released. They weren't really maintained over time, and most likely that may be because the folks didn't continue to meditate once they were released. So what he did then was he said, well, how can we sort of put this in a more secular way? Again, the struggle was with pulling it out of context and recontextualizing it in another setting. And he decided to sort of approach it. This was after Jon Kabat-Zinn had sort of come about with his mindfulness-based stress reduction, and after the folks Teasdale and others had put together mindfulness-based cognitive therapy, which was for relapse prevention in depression. Marlot's worked with his team to include mindfulness, described here, into an approach to combine with his relapse prevention therapy, which is primarily cognitive behavioral, and has now published a manual on this and done some preliminary research. Of course, unfortunately, he died midway through a lot of this, but he's got some graduate students who are carrying on. And so I've already talked about this a little bit here, but mindfulness-based relapse prevention really falls in this rubric here with a lot of other different therapies that are coming about now in psychology, including dialectical behavioral therapy, acceptance and commitment therapy. A lot of these therapies that we've been doing in psychology and offering to people and researching for about 20 years or so. Another therapy I do, which is for chronically depressed patients, is CBASP here, which was designed really with more of a focus on interpersonal mindfulness for folks with chronic depression, which is a whole other topic. And I'm not going to really focus a lot on the neuroscience of it, but I think it is important for you to note, just like John was talking about, all of these studies, because they have been typically researched in medical settings, have components of usually brain imaging, or at least EEGs or fMRIs that are helping us document that there are significant changes functionally and structurally as well in these people. As a psychologist, that's very interesting to me, but it's even more powerful for me to see actual behavioral changes and changes in quality of life for these folks. So the reason mindfulness is very helpful in substance use, if anyone has ever suffered from substance use disorders or had a loved one who did, and that's probably most of you in here, if you're like the majority of people in the United States, you probably intuitively can understand why the concept of mindfulness may be helpful for folks. Paying attention really helps focus people on this awareness of their triggers and responses, and can interrupt this sort of automatic reflexive behavior that's conceptualized as learned. And in the present moment, this is about the acceptance rather than using substances to avoid this emotion or then to judge yourself. You sort of focus on acceptance of the present and all that that includes, including emotions, and non-judgmental, so detaching from attributions and automatic thoughts that can lead to relapse. And these are the really powerful and helpful components of mindfulness that are used in the treatment. So it's patterned very much like MBSR. As we talk about, this is the focus I just mentioned. We talk a lot in psychology about the relationship. It makes me think of our presentations from earlier this morning. The doctor-patient relationship is really important in the mindfulness-based approaches, and it's really comes from sort of a Rogerian. Carl Rogers was the proponent of person-centered therapy, where there is this sort of acceptance, this non-judgmentalness, and that we feel is very important for the physician to have this kind of relationship. And I suspect this is why most of the providers, if you read MBSR or MBCT manuals, most of them are recommending that the providers have their own practice. And you might think, why is that necessary? But what it really helps to do is promote this in the provider, this person-centered approach, this sort of motivational interviewing style, if anyone's familiar with that. That's sort of a style of gentle curiosity, of non-judgmental, not pushing, but just sort of standing with the patient. So this sort of authenticity, unconditional acceptance are all hallmarks of a Rogerian therapy and motivational interviewing, and really are necessary if you're going to successfully do this treatment with folks. Some of the formal practices that are technically done in the mindfulness-based relapse prevention are included here, and very similar to things from MBSR, the body scan, the sitting meditation, walking meditation, and mountain meditation. And these are more formal in that they're done in the group setting when you meet with the patients, and you ask them to do this on their own. There are some things that we do in MBSR that are a little bit different. One of them is what we call the sober breathing space, because our folks are going to be going out into the world and encountering triggers and cravings constantly. This is one of the things they can do. You can see here, it's a wonderful exercise for anybody, even if you're tempted to eat cake or too much, of anything. Stop, pause what you're doing, observe what is happening in your mind and body. So many people don't do this. Breathe, that's bringing focus to the breath as an anchor to stay present. Expand awareness to your whole body and surroundings, and respond mindfully. We also talk to people about urge surfing. This is a component not just from mindfulness, but from relapse prevention also. The idea is really getting back again to that craving, the idea that a craving will come and rise like a wave. Many people on that wave, on the rise up, have a sense, a thought, a cognition, this will never end. It will get worse and worse and worse. And we help them understand that if they are given time, this wave is sort of reflective, not just of craving, but of your sympathetic nervous system, which cannot sustain activation forever. It will crest and it will fall. And part of the urge surfing is really just being with that, monitoring it in a gentle, curious way, and watching it pass. Very mindful, very meditative, something that most of these people never do on their own. So this really helps disengage a little bit. These are sort of the session themes, which you can see generally break down into some awareness, present-centered awareness, the mindfulness and relapse prevention sort of components, and then creating a balanced life. Like I said at the beginning, these folks are typically, their lives are chaotic by the time we see them. Their lives are out of balance. They have beaten up on themselves more than even the people around them who've beaten up on them pretty well too. So the bigger picture of creating a balanced life, being kind, compassionate to themselves, is really, really important. What we find typically in the results are what you might expect, that John's already talked about, the same thing that many other folks find, improvements physically, settling this sort of sympathetic nervous system response, more control of attention, and dampening reactivity to stress, and increasing positive emotions, which we know if they go on to do any other psychological work is really important. For too long, psychology focused on reducing negative, but we're finding more and more, and even in our own research, that it's much more effective if you reduce negative affect and increase positive affect. Combined, they work much better. And really importantly for the people with addictions, what we find is it really helps dampen this sort of reflexive automatic response. And we find evidence of this in the brain, which I won't go into on imaging studies, but also in their responses. So one of the first trials, and surprisingly, there's some literature out there, but really not a great deal. Like I said, we had a big setback with Alan Marlett dying, but people are still trying to move forward. But a lot of the studies that are underway just haven't produced any papers yet. So we're still looking at pretty old data. One of the first studies included about 295. This is after the folks he had in the prison system. And again, though, this is a mixture. They just sort of took a bunch of different people with different addictions and looked at them. Now, you might look at this and say, well, this is not really all that impressive. This is reduction in substance use. In the substance use world, this, believe it or not, is impressive. So what we find here is this is treatment as usual, which is typically something like AA or some sort of support group. And again, these are people with mixtures of different addictions. And so you see from baseline, they're sort of the same as far as any drug use or alcohol use, and a dramatic decrease in substance use for both. And this is actually common. There's a very large sort of non-specific effect of any kind of treatment in addiction, which makes it, this is why addiction research is so difficult. For many of people with addictions, you do anything and they get better initially, but then it doesn't last. And this is sort of what we're finding here. So post-test, immediately post-test in 2 months, the MBSR were significantly better than the treatment as usual, but then at 4 months out, they don't seem to have any sort of difference. They're both still better, which is good. But what we're working on now in our lab and many labs across the country are really tailored treatments to look at who, if everyone gets better to some treatments, well, who do we really need to focus treatment on to maintain it long term? And if we can do a little something for most people and they get somewhat better, that's great. But how do we really target who we need to work more with, who we can do less with? And that hasn't been done. It's just started. These are some more results from that same study. What they find is that there are increases, significant increases in acting with awareness and in acceptance. Cravings are where we're targeting from. Remember what we started talking about, were cravings. So looking at cravings, the MBRP group did have significantly fewer cravings that they reported throughout, which is important, and we'll come back to that. It's important because what they found in this study were this mediator effect. This means that changes in craving actually mediated the difference in substance use. So the people with reductions in craving are the ones who really reported decreases in substance use, and there's a connection there. So decreased cravings led to decreased substance use, which, you say, well, yeah, that makes sense, but we didn't have any evidence that that was really the case. And I'm going to show you some, I'm going to skip this because I want to get to the good stuff. So we'll talk more about cravings and the role there, but in this study, it looked like the mindfulness-based relapse prevention helped decrease cravings, which then led to substance use decrease as well. All right, so we'll file that away. That's what we had sort of hoped and thought we would see. We saw decreases in the substance use, increased mindfulness. We always get measures of mindfulness, and those increased over time, and reduced craving. So that's all well and great. Now I want to introduce you to some of the smoking literature. This literature is a little bit different because many of the smoking cessation studies have populations that are typically a little higher functioning. So often you can have people addicted to nicotine who don't have a lot of other comorbidities. A lot of people with comorbidities are addicted to nicotine, but it doesn't work both ways. So these are some research by Judson Brewer at Yale just pretty recently, where he compared mindfulness-based smoking cessation, and again, these are people actively smoking, with a freedom from smoking. This is sort of the American Lung Association's approach, sort of a mixture of supportive and cognitive-based therapy. And what he found is that there were significantly more reductions in the mindfulness-based approach than the freedom from smoking. But what he noticed in his data is that he measured mindfulness. The mindfulness, as mindfulness increased, the smoking decreased. But craving, even when craving was high, if there was high mindfulness, the smoking would decrease. And so what he proposes is this is a true uncoupling, that even while you're craving and wanting a cigarette, the mindfulness, there's something about the mindfulness that is keeping you from responding to that. And so he followed up with some neuroimaging studies, and that's indeed what he found, is that the areas, and I won't get into all of that since I'm not going to show pretty pictures like John did, but that the areas that, as John said, it's a whole region that is reacted in craving and then the behavior and the use. So that these areas became sort of uncoupled. So that even though I have craving and that area in my brain lights up, it doesn't automatically lead then to the behavior of using, which is huge because we know from research we're not going to get everybody to diminish their cravings. It's a very difficult thing to do. So with this sort of decoupling, the craving is still moderating or mediating in some ways, but it's a little more nuanced than we see in some of the other addiction research. He has adapted this to a mobile device application, which needs to be pilot tested, but is another interesting development that we're seeing, and which certainly would help disseminate some of this, because that's our other big problem. A lot of people can't access this kind of treatment, and if it is as promising as it's sort of beginning to look like, we certainly have a moral imperative to provide this for folks. So to wrap up with future directions, there still needs to be some information that we find on what, especially in MBSR, what is the effect of the mindfulness and what is the effect of the relapse prevention, this sort of cognitive component? Can they be untangled? There are many things that overlap in these two approaches. What are the unique mediators and moderators? Can we need to also modify it to really continue this and get some long-term data. And as John mentioned, we still need studies that look at comparing it to other really effective treatments. We haven't compared this to an anti-craving medication head-to-head. We haven't compared this to acupuncture or some other strategies that sort of have a rationale that demonstrate that they may reduce cravings as well. We haven't really looked completely at the role of stress. How are stress and craving related? They're similar, but they're not exactly the same. And we're looking at some of these in a current study we have. It's looking at MBRP versus treatment as usual, but we're focusing more on this link between stress and craving. And so we're specifically targeting stress induction in people with addiction, where, and no other study has done this, where we induce a craving and it's very stressful, and we're measuring heart rate variability as well as craving response, as well as behavior. And so we're hoping to see, sort of explore more this complicated relationship between craving, stress response, and behavior. And also look at the side effects. So far we've been fortunate, we haven't had any, but many of these people come from very traumatic backgrounds. They, like I said, they've got other complications in their lives, and it's completely likely that we will have some issues. People with abuse that comes to the surface, memories. So we really need to look at that. And if anyone saw Willoughby Britton when she was here a couple weeks ago, she mentioned this as well. This is something that no one's really looking at, but there are negative or adverse events that we need to keep track of. So the future, also we have maybe looking at prevention in general. Can we catch these people? I have young people here. This is my daughter's mindfulness-based research retreat that she hosted and with her friends. I think this is where the future is. Can we get these people early? And we have a mandate to do education. Can we train them early how to do these healthy things for themselves, how to not act impulsively or out of this sort of automatic learned behavior, and maybe inoculate them this way, not with a shot, but with mindfulness. And again, really important to me, how do we disseminate this? This shouldn't be for just wealthy people who can go to yoga and meditation, but we need to get it out to everybody and really make it accessible to those who need it. So I'll finish with that, and I thank you very sincerely for your time.